organizations that suggest how you should report. At the end of the day, you're going to have to make the decision for your practice. The end of the presentation has a bunch of slides that have key CMS resources that will help you as you define and implement your 2015 program. I like CMS resources. Whenever I'm looking for information about Pqrs 2015, I Google on what I'm looking for with .gov, because if your EMR vendor tells you the right way to participate in CMS and there you have a mistake, CMS is not going to be all that interested in the fact that you took their advice and not CMS's. So, all the resources at the end of this will be CMS resources. Disclaimers: we are addressing the Medicare program for PQRS eligible professionals that I will refer to as PEPs. This is not Medicare Advantage. This does not relate to Medicare Advantage. It's just Medicare fee-for-service. Also, primary care practices that may be fee-for-service but are also in an MSSP, Pioneer ACO, or CPCI would not be interested in this, and nor would specialists who are attributed to a Medicare ACO as a primary care provider. For those folks, the ACO handles their PQRS reporting. And you folks know who you are. Others who don't understand these crazy acronyms, don't worry about it. If you don't know the acronym, you're not impacted, and you belong here. These slides and comments are solely those of me, and I spend a tremendous amount of time and energy on PQRS, but this does not constitute legal or regulatory advice. Now, PQRS has a lot of options and details, and I will not be able to answer all the questions during this webinar, but the goal of this webinar is to give you a foundation for defining your practice's optimal 2015 direction, and to give you tips and URLs that will let you and your associates basically set a good direction for your practice. With that said, my consulting practice does focus on PQRS and has been focusing on it since 2010. And 100% of the time since fourth quarter of last year. So if you need help, we're here. Financial impact of PQRS. The most important thing is know your numbers. Addressing PQRS can take up an infinite amount of time and money if you let it. So it's important to know how much money you have at stake. This means knowing who your PEPs are and what their Medicare fee-for-service billing is expected to be in 2017. 2017 is what's important. Your PQRS participation in 2015 is going to impact your 2017 revenue. So once you know your PEPs and Medicare billing, expected Medicare billing, then you can use that information and the information on the next few slides to calculate the dollars at risk to your practice for non-participation and for participation with a focus on showing CMS strong quality. Who are PEPs? They are not the same as meaningful use EPs. They are doctors, just like for meaningful use, but PEPs, PQRS EPs, also include physician assistants, nurse practitioners, physical therapists, clinical social workers, nutritionists, and basically anyone that's paid under Medicare's physician fee schedule. So first thing is know who your PEPs are. The next thing to be aware of is what is PQRS's role in the CMS's value-based purchasing program. Value-based purchasing is could tie us up for a long time, and I don't want to distract us from it. But value-based purchasing is a topic in itself, and I don't want to distract us with it. But I'll highlight some changes. I'll highlight some key things about it. I'm sorry. For the Medicare B value-based purchasing program, CMS will categorize your practice as delivering low, average, or high-quality care. They'll also categorize whether you're doing this at a low, average, or high cost to Medicare. We're not going to talk about the cost component, but basically your clinicians and your practice's performance on its PQRS measures is what will determine how CMS sees your practice. Do they see you as low, average, or high quality of care? Now, what is the financial impact of Pqrs on your practice? If you do not participate properly in 2015 and you're a small practice, your 2017 Pqrs charges will be cut by 2% because of the Pqrs program and by 2% because of the value modifier program, the value-based purchasing program. So if you don't participate or don't participate properly, you're looking at a $4,000 cut per $100,000 of Medicare fee-for-service charges. If you're a larger practice, that being 10 or more PEPs, you're looking at a 2% Pqrs non-par cut and a 4% value-based cut, which puts you at $6,000 per $100,000 of Medicare fee-for-service charges. Okay, so let's say that you decided to participate and you participated properly, but some of your clinicians' performance on their measures isn't great. So for example, let's say you see a good number of COPD patients and want to report the spirometry-related measure for your docs that see them. If one of those docs is inconsistent with spirometry testing, or if he or she or supporting staff aren't great at documenting spirometry test results in a way that your Pqrs reporting method captures, that doctor's performance on that Pqrs measure will be poor. This isn't the end of the world because you'll still, if you're a small practice, you'll still avoid 4% of the cuts that occur for non-participation, but now the value-based purchasing program kicks in. If you're reporting your PEPs individually versus as a group, and we'll talk about that later, CMS will consider that doctor's quality to be poor. If you're a small practice, that's okay because you won't get a cut, but you also will not get the small practice bonus in 2017. If you're a larger practice, you will be cut for that PEP in an amount of 4% of his or her charges. You also will not get the bonus on his or her charges of 4 times the value modifier. So now, what are the options for 2015 reporting? You can make yourself crazy looking at them and just don't. Instead, know the financial impact of non-par and non-participation and also poor performance. Pick a direction and go. And whatever direction you pick, strong recommendation is that you save CMS documentation that shows that you're doing what they're asking for the direction that you're going in. By the time 2017 rolls around, if you're seeing a cut in your reimbursement, Medicare B reimbursement, you will have long forgotten the detail of 2015. So it's ideal to have a folder ready to pull out in case CMS is making a mistake in cutting your reimbursement. So the first thing to decide about 2015 is group reporting versus individual reporting. If you have more than one PEP in your practice, you get to choose whether you want CMS to look at your practice's quality of care as a group or as individual caregivers. Your goal is to show Medicare strong performance. Will that be easiest to do as a group or as individuals? If multiple doctors see the same patients, group may be the way to go. So for example, I support a practice with internists and a gastroenterologist, and they all participate in Medicare under one tax ID. The gastroenterologist is terrible with their EMR, and the EMR doesn't report gastro measures. It's really designed for primary care. So reporting for him for Pqrs would involve labor-intensive data capture and data entry. On the other hand, the 3 PCPs in the practice are great with their EMR, and it's an EMR designed for primary care, and so for that practice, group reporting is the right option. When you do group reporting, you only need to report 50% of your PEP's data as long as you report on at least 50% of the full group's Medicare fee-for-service beneficiaries that are seen in 2015. So that's a benefit to group reporting. For some practices. And also some technology vendors have developed efficient ways of doing group reporting, and that can be a big time saver and money saver when it comes to paying people to deal with your participation. A downside to group reporting is that you have to declare that you're doing group reporting early in the year, and you have to declare what method you're going to use, and for various reasons as the year goes on you may not want to stick with that. If it's worthwhile, if you're using an EMR, it's worthwhile to talk to your EMR vendor, if you haven't already, about what their group reporting methodology is. So if you want to do group reporting, you have to register between April 1st and June 30th of this year, and that's when you'll declare how you're going to report as a group. And you'll also have to list all of the PEPs that are in your group. So if your practice is looking at merging with another practice later in the year, if you declare yourself as doing group reporting, you may mess yourself up. Now, so here there are different reporting options for group reporting and for individual EP reporting. So first we're going to talk about the options for group reporting. One option, the most popular according to CMS, is using a qualified Pqrs registry. You would pick, folks that do this, pick a CMS-approved registry and report 9 measures covering 3 quality domains. That's for 2015. Now, there are 3 kinds of registries. There are the ones that need your practice to key in data on every patient that has to be reported for any one measure. There are the registries that your EMR vendor runs or has partnered with, so that you or they can do some magic and send the registry one big file of all your Pqrs data for each PEP that you have to report on. And then there are the registries that are third parties that have again partnered with your EMR vendor and can dial into your system, extract your Pqrs data, and send it to CMS. So when you're looking at registries, keep this in mind. Not all registries will let you report all measures. And the bad news about registry reporting is that the list of registries that CMS has approved for 2015 won't be available until, quote, late spring, early summer. So, if CMS, that list of CMS-approved registries typically says whether they allow for group reporting or individual reporting and what measures they allow for. But if you can't get it until, early June, and you have to declare whether you're doing group reporting or not by June 30th, you might not be in a comfortable position. It might be better to just go with individual reporting. Other group reporting options is the GPRO web interface. Given limited time, I'm not going to talk about that right now. There's plenty of information online for that. Direct EHR using EHR technology. So you can do your meaningful use and Pqrs reporting at the same time, and there are reasons why you might not want to do that, but you can do it. We'll talk about the reasons for perhaps not doing it that way later on, but I mention it here because you can do it. So direct EHR using certified EHR technology is an option under the group reporting methods. You can also report via data submission vendor. Meaningful use has 64 measures that EPs can choose from. So that's 64 measures. Pqrs has 250. So if you're with a specialty practice and the standard Pqrs, the standard meaningful use measures are not really applicable to your clinicians, then it may be better to pick from the 250 Pqrs measures, and the data submission vendors will not all report all 250 of those measures. So again, when CMS publishes their list of certified vendors, they'll tell you which vendors can report which measures. We hope. Okay, another way of doing, over here, another way of doing the group reporting is CAPS by a CMS certified survey vendor. There are, CAPS measures are basically where patients, there's a patient survey where patients give feedback on their perception of how your practice's quality. I'm not going to spend much time on this one because it's, in my opinion, not one that you particularly want to pay attention to. But I will say, as far as the CAPS reporting goes, my understanding is that practices of 100 or more EPs, Pqrs EPs, are going to have to do CAPS reporting for Pqrs this year. So now let's talk about individual reporting for PEPs. Claims-based reporting. This is the oldest method. Claims-based reporting for Pqrs measures has been around since 2007. The detail, the measure-by-measure detail changes every year, but the basic process has been around for a long time. Under claims-based reporting for 2015, for each PEP, you report 9 measures covering at least 3 quality domains and at least 50% of each EP's Medicare fee-for-service patients. What you basically do is you capture quality codes on the claims before you submit them. Some of the codes show strong performance, others weak performance, and others a punt. So for example, most of the measures, what I mean by a punt is a lot of the measures have the choice of, let's take medication reconciliation as an example. One of the measures is, yes, I did medication reconciliation at this visit. Another measure is, no, I did not do medication reconciliation at this visit. That could be perceived as a punt. That would not be perceived as a punt. That would be perceived as a bad thing. But a lot of the measures do have something that says, no, I didn't do this, or I didn't capture the data to do this, and that's not necessarily a horrible thing. Okay, on to registry-based reporting. For each PEP on registry-based reporting, you report 9 measures covering at least 3 quality domains, again, and at least 50% of your that particular EP's Medicare fee-for-service patients. You get to pick a registry from the approved list, and as I said, the approved list isn't out yet, but it's supposed to be out shortly. Registries are typically provided from professional societies. EMR vendors typically partner with registries, and you can also get a recommendation for a registry from other practices that you trust. A key thing to look at in a registry is some of them let you see your PEP's performance before they submit the data to Medicare. That's a beautiful thing, because if you can run a PEP's numbers halfway through the year and find out that performance is not what the practice would like, you can focus on that for the second part of the year and bring those numbers up. Other options, you can use your EHR to report your Pqrs measures. You can use a qualified clinical data registry, which is a data collection registry sponsored by an organization that has gotten CMS approval to analyze quality measures that are different from the ones that are on the list of 250 or so Pqrs measures. And PEPs that submit to an approved an approved QCDR get credit for Pqrs participation. Now, my personal favorite way of reporting Pqrs for individual EPs is measure groups. Measure groups are sets of measures by condition that have to be reported via a registry for at least 20 patients, of whom at least 11 are Medicare fee-for-service beneficiaries. There are 20 measure groups for 2015, and examples are asthma-focused, COPD-focused, there's a preventive care measure group, diabetes, inflammatory bowel disease, the things that are listed here. What's nice about these is you only have to report 20 patients per PEP. It's a lot less data intensive than pretty much all of the other reporting methods for individuals. If you're doing group reporting, you cannot do it through measure groups. This is only available to individual PEPs. Okay, key changes from 2014 to this year's program. The stick is getting out and getting bigger. No more. You don't get a bonus this year for participating this year. Your bonus, if you get one, will happen in 2017. And reimbursement cuts will also happen in 2017. And the reimbursement cuts are larger than they have been in the past. The bar for participation is going up. In 2014, for 2014 Pqrs, both the claims and registry options only required reporting of 3 measures in 1 quality domain. 2015 requires 9 measures in 3 quality domains. And the 2015 measure groups have more measures in them per group than they've had in the past. But that's not that bad. So some of the measure groups in 2014 had 4 or 5 measures. Now they might have 8 or 9 measures in them. The risk with measure groups is that it's very possible that if you go in that direction, maybe your performance on some of the measures won't be that great. But we'll talk about, but that might not necessarily mean a financial impact that is worth worrying about. As always, the detail of the Pqrs measures has changed this year. Some measures have been added, others deleted. The measures that have stayed may still have changed detail. For example, when it comes to exclusions, allowable exclusions from the measure, coding may have changed. There's a lot of change that can happen. More specialists this year will find measures that are applicable to them. But fewer measures can be reported via claims versus registry. Lastly, you have to factor in ICD-10. Basically, for each Pqrs measure that you report, if you're using claims-based reporting or registry-based reporting, whether you're a group or individual reporting, you will have to, instead of selecting patients that qualify for any one measure by ICD-9 code, which is how a lot of the measures do it, for all dates of service of 10/1 or later, you will have to select on ICD-10 code. The good news is the measure specs do have lists of all the ICD-10 codes that relate to a particular measure, so at least you have that. Now, what is the status of public reporting of measures? The status is foggy. CMS has said that only those measures that meet all public reporting criteria and resonate with consumers will be included. So what measures resonate with consumers? Hard to tell. CMS has said that in late 2015, if technically feasible, 2014 EHR registry and claims measures will be made available to the public for individual eligible professionals in late 2015, and they say if technically feasible. For group practice measures, only the group's aggregated performance will be reported, not those of individual EPs. And on the individual measures, they're only planning to report 20 that are consistent, that they consider to be consistent and of interest. The 20 include hemoglobin A1C, heart failure measures. If you participate in the Million Hearts program, those measures are expected to be reported. They are going to report on physician compare influenza immunization, pneumococcal vaccination, breast cancer screening, coronary artery disease, and basically a handful. Whether or not this really happens is up in the air. CMS has not said what they're going to do with the 2015 measures. They haven't gotten very specific about that. I have seen here and there that they're going to put them into data files and make them available, which is a little bit scary. But they go back to, they're only going to include in those data files all valid and reliable measures. And what is valid and reliable is hard to know at this point. Now, your easiest option for Pqrs reporting may or may not be your best. A question I like to ask is, what do your doctors and other PEPs think of the easiest measures to report? If they think they're stupid, it might not be wise to do the easiest measures. My personal opinion is that it's hard for doctors to go to work every day and feel like they have to do something stupid, and if they don't do it, it's going to be held against them. What you see here, 2015 Pqrs Individual Claims Registry Measure Specification Supporting Document. On the CMS website, if you find these measure specifications, you will find the detail for all of the Pqrs measures, all 250 of them. And even though it's a scary-looking document, it is a 600-page document. It's very well organized, and each of the measures, it starts with a list of all the measures to choose from, and then each of the measures has maybe between 2 and 5 pages of detail. In that detail is CMS's rationale for asking doctors to report that measure. And in my experience, when I showed that detail to the doctors, it makes them think. And sometimes they see the rationale, and sometimes they still think the measure is stupid, but at least it gives them some insight into CMS's thinking, and it becomes more of a clinical consideration than, you know, a stupid paperwork thing. So my personal preference is to, you know, if the doctors are open to it, to at least have conversations with them about what measures they feel they want to report. Okay, let's say that you're thinking about claims-based reporting. With claims-based reporting, you can't see how any one PEP is doing before you report the codes. You basically code the claim as it's going out the door, and, you know, that's that. If you have good EHR practice management system integration, sorry about that, you can set up your EMR system to autocode your Pqrs. For some of the measures, you can set up your EHR system to autocode the Pqrs codes. But you have to be careful not to accidentally set yourself up for fraud. So medication reconciliation is a good example. If your practice has a policy for everybody to do medication reconciliation at every visit, you know, and so you decide to autocode that every medication reconciliation has happened, maybe that's not what's really happening, and you can expose yourself to risk. If there are HIEs out there, if you're using a health information exchange and your doctor hasn't looked at the HIE's list of medications for a patient, but somebody coded that medication reconciliation is done, then you could get yourself into trouble. Now, for practices of fewer than 10 PEPs, in some cases there could be minimal downside to autocoding, as long as it's not fraudulent. Remember, the smaller practices, the big risk is not participating in Pqrs properly. Those that don't participate are looking at a 4% cut in their revenue. But if you participate and your EPs don't do very well on their measures, you won't get any cuts. You also won't get a bonus in 2017, but at least you've protected your practice from a 4% cut in reimbursement in 2017. So you might want to autocode to, if you find a measure that says, I just didn't document this, that's considered a punt. You're not saying that you didn't do what the measure wants. You're not saying that you did do what the measure wants. You're just saying, you know, I didn't document this. And so that might be something that you might want to consider doing. EHR reporting. This may sound like the easiest reporting option. What this means is that you report, for example, your Pqrs measures and your meaningful use measures at the same time. But for meaningful use, you don't have to have measures that look particularly good. As long as you report 9 of the 64 measures, you will meet your requirements for getting your meaningful use bonus and avoiding your meaningful use cut. Pqrs, that's not the case. That's not necessarily the case. Another consideration for EHR reporting is if you have, it's still possible that for meaningful use, measures will, only 90 days worth of measures will need to be reported. Pqrs, you'll need to report 12 months worth of measures. Another concern with EHR reporting is what is your EMR vendor's history with EHR reporting of Pqrs measures? If they're new at it, you might not want to use that functionality this particular year. Lastly, public reporting for Pqrs is a consideration. Again, your EHR measures for purposes of meaningful use don't necessarily have to show very strong performance, but for Pqrs, they could be made public on Physician Compare, and so you may or may not want to do that depending on how those measures look. Measure groups, the only downside to reporting for measure groups that I could think of is that CMS may not consider measure group reporting to give them enough data for calculating your value modifier, bonus, or cut. 2015 is the first year that CMS applied the value modifier to any practices, and they only applied it to practices of 100 or more eligible provider practices. And there's a report available through CMS that talks about how that went this year. In some cases, they did not do a cut or a bonus because they felt they didn't have enough data to go either way. And so it's possible that measure group participation in Pqrs could bring the same sort of action from CMS or not. But basically, saying that a practice's performance has to be judged based on 20 patients is, questionable, in my opinion. Okay, registry reporting. Registries, the downside is it's often a lot of data entry, but it also has the largest number of measures to choose from. It also lets you choose. Most measures can be done by a registry. You may find measures that cover a small number of your Medicare patients, which means that the burden of data entry isn't as bad as it might look. And you may be able to create office workflow that makes data capture via registry more or less burdensome. Then remember, there are different kinds of registries. There are some registries that now can dial into your system and pull a file rather than having you key in data. Those are going to be more unusual, I think, or harder to find than the registries where you do data entry. But really, your EMR vendor is the one to talk to about registries that can simplify data entry. Now, the next slides are all Pqrs resources. Don will be sending these out to you all. When you're looking for Pqrs information, you can always just do a Google search on Pqrs, and that pqrs.gov. If you do a Google search on pqrs.gov, you'll get to the CMS website and not just to a lot of entities that are talking about Pqrs but may or may not have the best information. The CMS website itself is right here. Something that can be confusing. If you're doing group reporting and you call the QualityNet help desk, the prompt that you get is, if you are calling from a GPro, press 1. That basically, if you're doing group reporting, you want to press 1. You're not necessarily a GPro. GPro stands for Group Practice Reporting Option, but if you are doing group reporting, this is the option to press on the call. It's been said that when you call the QualityNet help desk, you sometimes get, if you call 5 times, you get 5 different answers. The thing to do is document the answer. for a list of Pqrs eligible providers, there's this link here. The list of the measures is here. This document is just a list of measures. It doesn't give you any measure detail, but it does tell you which measures can be reported via claims versus registry and provide some other information. To appeal cuts that are based on participation 2 years ago, this is the website. At the start of every year, you have the opportunity, if your reimbursement is cut because of Pqrs, you have the opportunity to appeal, but that's only at the start of the year. So in 2017, you'll have, if you're cut, you could have the opportunity to go back and point out how you participated in 2015. These things show you the registry reporting and measure groups reporting, and this is the physician compare link. Right now, if you go out there, you won't see any specific measures, but as I said, CMS is currently planning to publish more detail at the end of this year, and what they'll be publishing are the 2014 measures. With that said, any questions? And I know there's a lot of information that we covered.
Cynthia, I'm not sure that you can see the questions in the question box. People did not use the chat. They used the question box.
And I cannot see them.
Okay, so I'll read you the first question.
Okay.
I'm working for a neurologist that is listed as a hospitalist as far as meaningful use under our tax ID. I will be attesting for Pqrs for 2015 via claims and have found only 2 measures he qualifies for. There are additional measures, but he does not practice them, such as hypertension, which he will take into consideration for treatment but does not treat. Therefore, I'm not reporting them. Am I correct?
I don't know the answer to that off the top of my head. Best to do is to call QualityNet on that one. But if you can't find 9 measures that apply to him, even if you just don't find 9 measures, there's something called the measure applicability validation process. So, and that's where CMS looks at, it doesn't require registration, it doesn't require asking for a MAV process. At the end of 2015, CMS will look at how your doctor has reported and decide whether he is mistaken, whether or not there's a mistake, and there really are more measures relevant to him than you thought. The MAV process there are documents on the CMS website that define how they'll make that decision, and so I'd suggest you look at those. You can Google on Pqrs MAV, M-A-V, for Measure Applicability Validation, and .gov, and you should be able to get the answer.
Okay, next question. CMS has retired some of the emergency department related measures. For 2015, there will not be enough measures for emergency department providers to report. Can you provide any suggestions?
Yeah, I've heard that elsewhere, and there may be a frequently asked question about that, but again, the MAV process is what could apply, and I would give the QualityNet desk a call. Or if you'd rather just look around on the internet, that will be a frequently asked question.
Okay. We are under the impression for 2014 we must meet 9 measures in 3 domains. You indicated differently for 2014.
For 2014, you only needed to meet 3 measures in 1 domain. 2015 is the first time you have to report 9 measures in 3 domains. If, and I should say, if you're doing claims-based reporting or registry-based reporting.
Okay. Can we select CA-HPS for Pqrs for a group which also services many outpatient departments? How does CA-HPS work? So 2-part question.
Okay. For 2015, my understanding is that you can, and I haven't worked with CA-HPS, so I can't really speak to that. So sorry. But I know that you can just do CAHPS for 2015. My understanding is you also have to report some measures with the CAHPS measures. But for example, for some practices of certain sizes, if you do CAHPS through an approved Medicare survey vendor, you only have to do 6 measures, Pqrs measures, in addition to that. And that's based on practice size. If your practice is a certain size, you can do it that way.
Okay, there's loads of questions about a printable version or downloadable version of the presentation. We will be emailing the presentation to all attendees. It will also be posted relatively soon on our website behind the members-only firewall. Another question we just came in, we are doing registry reporting for 2014. Did you say we need only 3 measures? We didn't hear you.
Measure groups are done through the registry, and if you're doing measure group reporting through the registry, you're reporting however many measures are in a particular measure group for 20 patients, including 11 Medicare patients. If you're doing just basic registry reporting, then for 2014, it's only 3 measures in one quality domain. So, but honestly, I would be I'm wondering if I'm missing something. So, if you want to reach out to me, I'd be happy to talk a little more about your situation and make sure that I'm not giving you bad advice.
Okay, next question. We have an internist who only sees our patients in the hospital, sees no patients in the office. How will he be affected?
He's got to participate. If he bills under his own tax ID and he's not paid by the hospital for what he does, then he's got to participate in 2015 if he doesn't want to get the cuts that I talked about in 2017.
When is the 2014 deadline?
It passed. Sorry. I believe it was, actually, I'm sorry. It may be the end of this month. I don't know. I would have to look at that. I don't know that answer offhand. I'm pretty sure it's the end of this month. So you still have about a week or a little less.
Okay, there's no other questions at this time.
Okay, actually, Dawn, on the thing that I just mentioned about the deadline of March 31st is when, if you're doing registry reporting, that's when the registry has to get your data to CMS. And so a lot of registries have given an earlier deadline for you getting your data into them. So that's just something to keep in mind.
Someone just posted that it was March 20th.
And I would check on that. It might be March 31st. There's a lot of detail in all this and a lot of confusion. And CMS extended the February 28th deadline for EHR attestation to March 20th. But I think that the Pqrs deadline was always March 31st.
It says March 25th for NJ High Tech.
Okay, well, NJ High Tech is a pretty authoritative entity, so. It's possible, though, that NJ High Tech, March 25th might have been their deadline to their practices, but NJ High Tech is giving itself until March 31st, from March 25th to March 31st to do submissions for the practices that work with them. So bottom line is NJ High Tech might have been, March 25th may have been NJ High Tech's deadline to you folks, whereas their deadline to CMS is March 31st. That's just a possibility.
No other questions at this time.
Okay, well, thank you all for participating. I hope I didn't overwhelm you. I hope I made sense. And thanks again.